Hi everyone, welcome to this first video on what will likely become an ongoing series throughout the semester. As I'm sure you realize, over the next few weeks we have a lot of material to cover in a relatively short period of time. So I wanted to make some videos for you to kind of review some of the more complicated issues that we'll be discussing that you can use for review or to prepare for class for your lectures. So this is going to be Cardiovascular Emergencies, Chapter 15, and in this video we are going to be discussing arrhythmias and the basics of how to read an EKG tracing. So the mechanical pumping action of the heart can only occur in response to an electrical stimuli. This is an electrical impulse that sets off a chain reaction in the heart cells to generate a beat. Partially, this is controlled by your brain and your central nervous system, specifically your autonomic nervous system. If we think way back to our EMT basic class, we remember that the autonomic system is divided into our sympathetic and our parasympathetic systems. The sympathetic system is responsible for our so-called fight or flight stimulus. So this causes increased cardiac output, vasodilation, increased respirations. We need to increase our cardiac output because our body is sensing that we're in trouble and we are going to need to either fight or run away. On the opposite side, we have the parasympathetic nervous system, which has the opposite effect. This is our body at its relaxed state. So we have decreased heart rate, decreased respirations, vasodilation, everything's fine and your body's nice and relaxed. However, one of the really special properties about heart cells, the heart tissue, that makes it so amazing is that each individual cell is able to generate a beat. This is the automaticity property of the myocardium, which is our medical terminology for the heart muscle. Each cell within the heart is capable of generating on its own an electrical impulse that can set off a beat. However, if every single cell in the heart was firing in a disorganized manner, then we would not be able to actually contract the heart in an effective way to actually move blood into the vascular system. So typically, your heart follows a conduction pathway. We can think of this like power lines. The electrical impulse starts at the pacemaker side of the heart and runs down the power lines all the way into the bases of the heart, into the ventricles, so that we can contract and actually eject blood out of the heart in an organized way. When we look at an EKG tracing, we are actually looking at the path that the electricity is following. We are looking at the power lines to make sure that electricity is traveling in a correct way. And we can actually see when the electrical impulses are disorganized or abnormal, or if it's having to reroute the conduction system around an area of dead or damaged tissue, such as in the case of a heart attack. So in this picture, we actually see the power lines of the heart. This is the electrical conduction system. Now, it's important for you to know that this is not necessarily a physical structure of the heart. So we can't cut a heart open and see the electrical conduction system within it. This is just simply a line of cells that are supposed to respond. So this isn't a physical structure. This is just the normal route that the electricity should take along the cells of the myocardium. We see the 6 parts here listed to the right. It starts out with the sinoatrial node, or the SA node. The SA node is the pacemaker of the heart. It has an intrinsic rate of 60 to 100 beats per minute. So generally, if the SA node is functioning normally, you're going to have a heart rate between 60 and 100. So the SA node fires and travels down these internodal pathways that we see right here between the SA and the AV nodes. The electricity traveling along those internodal pathways contracts the atria. So SA node fires, and then both atrias squeeze their blood out of themselves and into the ventricles. Next, the electricity hits the atrioventricular node, or the AV node, and that is the junction. So let's say that our SA node was damaged. That area of the heart has some kind of damage, and now our SA node is not firing anymore. Well, the AV node at the junction will actually pick up the task of becoming the pacemaker of the heart, and it's going to start to fire at its intrinsic rate, which is a little bit slower. It beats at a rate of about 40 to 60 beats per minute. So the AV node's job is to conduct that impulse from the SA node down into the ventricles. So we're going to travel into the bundle of His. The bundle of His will separate into the left and right bundle branches. And then at the terminal ends of the bundle branches, you see those kind of hairy outcroppings at the bottom. Those are the Purkinje fibers. The job of the Purkinje fibers, when they are stimulated, is to contract the ventricles. So when the electrical current runs through the Purkinje fibers, the ventricles squeeze, and that is what pumps the blood out of the heart and either into the lungs or into the peripheral circulation. So this entire process of contraction is called systole. When we take our blood pressures, we have a systolic pressure and a diastolic pressure. The systolic pressure is a measurement of blood pressure of the heart at its maximum contraction. So the contraction of the heart is systole. When the heart relaxes itself, that's called diastole. So cardiac muscle, myocardium, is very different from any other muscle tissue in your body. If you've ever taken AEMT, you remember that there's 3 kinds of muscle tissue found in the body. We have skeletal muscle, which is responsible for movement. You know, this is our biceps and triceps and all of the skeletal muscles in our body. We have smooth muscle, which is found inside the blood vessels, which allows for vasodilation, vasoconstriction. It's also found in our intestinal tract and is responsible for peristalsis, which is that squeezing motion that pushes digested food through our GI tract. And then we have cardiac muscle, which is a category all on its own. So myocardial cells have 3 electrical properties of excitability, conductivity, and automaticity. Excitability is the ability of cells to respond to an electrical impulse that they are given. Conductivity is the ability of those cells to conduct the electrical impulse from one cell to another in an organized fashion. And automaticity is a very special property that is really just found only in cardiac tissue, and this is the ability for each cell to generate an electrical impulse and contract spontaneously all on its own. Normal impulses of the heart, again, start at the sinoatrial node. So the automaticity of the heart allows that group of cells in the SA node to initiate an electrical impulse and generate a beat. So as long as that impulse comes from the SA node, the other myocardial cells will contract in an organized line as that impulse reaches them. However, if no impulse arrives, then the other myocardial cells are capable of creating their own impulses and stimulating a contraction, which is very good. Otherwise, if we had a heart attack or something that damaged the SA node, we would immediately die. But like I said in the previous slide, the junction can take over, the AV node can take over and become the pacemaker of the heart, even though it's at a slower rate of 40 to 60. And now let's say that even the AV node fails. The Purkinje fibers can take over and become a pacemaker as well, but they are going to contract at an even slower rate of about 20 to 40. So this is a very helpful property of the heart, that if there's damage to one part of it, other parts of the heart can pick up the slack and contribute an electrical impulse to generate a beat. And we can actually see those changes on the EKG as changes from the normal waveform. So we've seen what the normal cardiac conduction pathway is, which will generate what we call a normal sinus rhythm. It's a normal heart rate, normal rhythm that generates from the SA node, from the sinoatrial node. Sinoatrial node, sinus rhythm. Any abnormality of that heart rhythm is called an arrhythmia. One particular arrhythmia that you should know about is ventricular fibrillation. This is where all of the cells in the heart are firing all at once, trying to generate a beat. And if you were to open this person's chest and look at their heart, it would look like it was just quivering and shaking inside their chest. This is the rhythm that we defibrillate with our AED or our defibrillator on our cardiac monitor. There are also several arrhythmias that could possibly follow a myocardial infarction or a heart attack, because since a portion of the heart tissue is damaged, the conduction system has to reroute itself around that damaged part. So we'll actually see that as a change in the EKG's waveform. Usually this might be in the form of a premature ventricular contraction, which is when the ventricles give a little extra squeeze when it's not their turn to squeeze. And usually those are pretty harmless. They're fairly common, and they usually respond well just to applying some oxygen. This is usually because the cells are irritated because they're not getting enough oxygen. However, other arrhythmias like ventricular fibrillation and a few others can be dangerous or even lethal. Ventricular fibrillation is a lethal rhythm that if it is not defibrillated very quickly can result in asystole, which is our flat line dead right there. So this is a little terminology that you should be familiar with. Tachycardia, we already know, means a rapid heart rate. If our normal intrinsic sinus rate is 60 to 100 beats per minute, anything above 100 beats per minute is classified as tachycardia. On the other side of the spectrum, we have bradycardia, which is a slow beating of the heart. So this is 60 beats per minute or less. The thing with tachycardia and bradycardia, remember to treat your patient and not your cardiac monitor. Actually look at your patient and see how they're doing. What's their perfusion status? Are they pink, warm, and dry? Do they have good mental status, alert and oriented, GCS of 15? Some people just always are a little bit tachycardic. Some people are always a little bit bradycardic. You remember that you need to treat your patient, not your equipment. Use your assessment skills. Now, the big bad rhythms that you need to know about, besides obviously asystole, which is our flat line. This is a dead patient with no electrical activity happening in their heart whatsoever. It's pretty hard to fix that. I haven't really found a cure for death yet. If you find it, please let me know. But I do have a cure for ventricular tach and ventricular fibrillation. So ventricular tachycardia is an extremely rapid heart rhythm. This is usually about 150 to 200 beats per minute, and it does not originate in the SA node. This is the ventricles just running away haywire. So the ventricles are contracting at that 150 to 200 beats per minute. The problem with that is that when the ventricles contracting so quickly, it's not giving them time to fill up with blood between squeezes. So our cardiac output is extremely decreased. These patients are going to be pale, cool, clammy, diaphoretic, altered mental status, could even possibly stop breathing. They're going to show signs of severe cardiogenic shock. This is a rhythm that can be corrected by defibrillation. The other rhythm that can be corrected by defibrillation is ventricular fibrillation. This is the one that I just told you about, which is the just quivering of ventricles. So whereas in VTAC, the heart is still trying to beat in an organized manner, we're still having ventricular contraction. And even though we have very reduced cardiac output, there is some blood coming out. With VFib, no blood is coming out because the heart is not creating any beats. There's no blood getting to the body. There's no blood getting to the brain or to the vital organs. If you do not treat this, and I mean if you do not treat this within a couple of minutes, it was going to result in asystole. They are going to die. So as soon as you see ventricular fibrillation, and I'll show you an example of that EKG in a few minutes, you must defibrillate this patient. I cannot stress that enough. Rapid defibrillation is going to be one of the #1 lifesavers for these VFib patients. Now, of course, because there is no blood moving through the vascular system, these patients are going to be pulseless. So this is why the minute that you don't feel a pulse, you need to start chest compressions and immediately ask for an AED or a defibrillator. When you put your AED/defibrillator on the patient through the paddles, it is going to read whether the patient is in asystole or a V-fib or a V-tach, a shockable rhythm. If it is a shockable rhythm, then you will be instructed to deliver a shock to the patient. Before we look at some cardiac strips and I show you how to read them and what it is we're looking at, I wanted to show you a sample of EKG paper. There's lots of stuff on here, don't worry about it. The only thing that I want you to know at this level is to notice that 3-second mark at the very top, those little black lines at the very top of the page. Those are separated into 3-second intervals. So when you are looking at a strip of EKG paper, you want a 6-second strip, meaning that you should have 1, 2, 3 black lines at the top of your page. You can calculate the patient's heart rate from looking at the strip by printing off a 6-second strip and counting how many beats are happening in those 6 seconds and multiplying by 10. So if I print out a 6-second strip and I see 6 heartbeats on that strip, then I can calculate that my patient has a heart rate of 60 beats per minute. So that's really the only thing at this level that you need to know about EKG paper, is just how to calculate your patient's heart rate. So about this point is where EMT and paramedic students look at all this mess of graphs and think, okay, never mind, I'm just going to go work at McDonald's. It's fine. Don't worry about it. This is actually pretty easy if you know what you are looking at, if you understand what the waveform stands for. So look at this very first wave on this EKG tracing. So we have the P wave. The P wave is atrial depolarization. So this means that the atria are contracting. If you look underneath at the picture of the heart, the atria are highlighted in red. So the P wave is the atria contracting and squeezing their blood into the ventricles. So SA node fires, contracts the atria squeeze. That is the P wave. So now we have that little pause. During this little pause, this is when the impulse is traveling to the AV node, to the junction. And then it hits the bundle of His, and the bundle branches and gets down into the Purkinje fibers. When it hits those Purkinje fibers and the ventricles squeeze, then we get this QRS complex. This is ventricular depolarization. That means that the ventricles are firing. The ventricles are contracting and squeezing their blood out, which ejects blood out of the heart and into either the lungs or the peripheral vasculature. So P wave is atria, QRS is the ventricles. Now we have another little pause, and then the T wave, which is the repolarization of the ventricles. Basically, the ventricles are resetting and getting ready for the next beat. The atria repolarize as well, but that action is kind of hidden by the QRS complex, so we don't really see it. It's buried in the QRS. But we do see the ventricles repolarize, and that is the T wave. So P wave is atria, QRS complex is ventricles, and then the T wave is the ventricles resetting and getting ready for the next beat. Don't worry yet about the U wave. So if we look over to the right, we see a normal sinus rhythm, and for each beat we've got a P wave. So here's the atria, and then here in the QRS complex is the ventricles, and then we have a T wave resetting, getting ready for the next stimuli, the next contraction of the atria with the P wave. So this is a normal heartbeat because we have P waves, we have nice upright QRS complexes, we have a T wave, and the rate is between 60 and 100 beats per minute. Underneath that we have tachycardia. So we have all of the same structures. We have a P, we have a QRS, and we have a T, but it looks like it's compacted. They're kind of all tight together. So this rate is above 100 beats per minute. Underneath that, we have an example of bradycardia. And again, we have a P wave, we have a QRS, and we have a T. Okay, so then all of the parts of the heart are firing just as they should, but it's firing too slowly. This rate looks like it could be about 40 beats per minute. So this is bradycardia. Finally, underneath, we have an irregular heartbeat. This looks like just a sinus dysrhythmia. And we still have all of the same stuff. We have a P wave, we have a QRS, and we have a T. but it's not in a nice regular rhythm like the normal heartbeat up there is. The normal heartbeat has the same amount of little blue squares in between each QRS complex. If we look down here at the bottom at the irregular heartbeat, here I've got just, one square, I guess we can say that's maybe 1.5 squares between some beats, and then I've got 1, 2, 3, 4 squares between the next beat, and then 3 between the next beat. So it's not regular. This is just a sinus dysrhythmia. So if you see that, that may or may not be a cause for concern. Some people have naturally irregular heartbeats that they live with, and they're just fine, and they might not even know that they have it. If you see something irregular, it's always a good idea to ask the patient if they've ever been diagnosed with an irregular heartbeat or any kind of heart problems. You just want to know if this is something that's chronic or a new onset. But in most cases, something like this, if I saw this on a cardiac monitor, I wouldn't be terribly worried about it. So the big takeaway from this slide is that I want you to understand what you're looking at when you're looking at this strip, what these waves signify. P wave is atrial depolarization, QRS is the ventricular depolarization, and the T wave is the ventricular repolarization, the resetting, and the atrial repolarization is buried in the QRS complex. Okay, now finally I'm going to show you a few arrhythmias. Please remember that if you have somebody who is in an unstable VTAC or in ventricular fibrillation, eventually that will resolve itself, and unfortunately it resolves itself by turning into asystole, which is a complete lack of electrical activity in the heart. So if you see VTAC or VFib, you need to act quickly. So this is just kind of a review. It's similar to the last slide. Up at the top we have sinus tachycardia. Somebody whose sinus tach of about 100 to 120 beats per minute, I'm really not all that worried about. I'm looking to see why they're tachycardic, what's going on with them physiologically that's making their heart beat quickly. But when you get into the rates of like 150 and above, what you would refer to as supraventricular tachycardia or SVT, then we start to run into the problem of the heart is contracting so quickly that it's not giving itself time to fill up with blood in between beats. So if I don't have enough blood inside of my heart before it beats, my cardiac output is going to go way down and my perfusion status is going to be terrible, and this can lead to cardiogenic shock. So you want to not only look at your monitor, but look at your patient and determine if they are stable or unstable. B is a sinus bradycardia. Again, this is a slow heartbeat of less than 60 beats per minute. And again, what we're worried about is cardiac output. Are we pushing out enough blood from this heart to perfuse the brain and to perfuse the vital organs? So somebody who has a heart rate, I had a patient who had a heart rate of about 28, and we got called because of syncope. She kept passing out, and as soon as we put her on the cardiac monitor, we figured out why she was passing out, because her heart rate was 28, and every time she stood up or even tried to sit up, the blood was not moving up to her brain and she would pass out. So we had to actually intervene with medications to speed her heart rate back up and bring her cardiac output back up. Ventricular tach. This is another one that you need to know. This is one of our shockable rhythms. Look at your patient. Are they stable or unstable? You can tell that the patient is unstable when they have signs of hypoperfusion, signs of shock, altered mental status, cool, clammy skin. They just look terrible. They look like they're going to die. If you have an unstable VTAC, this person may lose consciousness, may stop breathing. So you're going to need to defibrillate that. Ventricular fibrillation, this is the one I really want you to look at down here, letter D. So we notice if we compare letter D to letter A has our nice P's, QRS's, and T's. Where is any of that in D? We don't see anything. This is just a crazy squiggly line, and that's signifying that there are so many cells in the heart that are trying to fire. Every cell in the heart is trying to start a beat. It knows that it's not beating and it's trying to restart itself. So the heart is just quivering. We've got this disorganized, widespread electrical activity. You can think of it as your heart having a seizure. And this is not moving any blood out of the heart. So their cardiac output is 0. Their pulse is 0. Their blood pressure is 0. So this is what we commonly see in cases of cardiac arrest. If we get there early enough, we can find VFib and we can defibrillate that, hopefully back into a nice normal perfusing rhythm. If left untreated, the VFib will turn into asystole, which is this flat line here. You notice it's not completely even. That can be due to you moving the monitor around or some kind of artifact in the room that's interfering with the monitor. But there's no upward or downward deflection of this line really in any meaningful way. This is a complete lack of electrical activity in the heart. This heart is dead. We can still work this patient up. We can still give them stuff like epinephrine, we can do chest compressions, and we can try to restart it. But you have a much better chance of restarting a heart that is in VFib or VTAC than you do of a heart that is in asystole. So you want to try to jump on your resuscitation before they get to this point, because it's much, much harder to do when they get to asystole. Not impossible. Asystole is also not a shockable rhythm. So if you've ever watched any medical show, somebody will flatline and then they'll defibrillate the patient. It's very dramatic and they come back. That does not happen in real life. Asystole is not a shockable rhythm. You have to have some kind of electrical activity going on in the heart in order for defibrillation to be effective. So really all we can do for asystole is chest compressions, airway management and ventilation, and lots and lots of epinephrine, and try to stimulate that sympathetic nervous system to stimulate the heart to try to start beating again. At the AEMT level, this is really the main rhythms that you're going to need to be able to recognize. So I just want you to take a moment, look in your textbooks, kind of study over these figures. One thing I would like to point out about the VTAC is that if you look at it, it does not look like a normal waveform. First of all, I don't see any P waves in here. Look around and see if you can see one. There really aren't any. So we know that this is not coming from the atria or even from the AV node. It's just this wide complex. And another name you might hear for VTAC is wide complex tachycardia, because all I see here is a QRS, and it's not nice and tight like the normal sinus rhythm is. It's really wide and just bizarre looking. So if you see that, that is a ventricular contraction. And then we're going to count the rate. If this is a 6-second strip, his rate is at 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 times 10 is 90. So the intrinsic rate for the ventricles is between 20 and 40. So 90 is really way too fast for a ventricle to be beating. That's why we call this ventricular tachycardia. So just be familiar with these rhythms, these strips. This is what is testable under National Registry. This is stuff that you need to be able to recognize in the field. You need to recognize when there's a funny little beat happening that shouldn't be there. And you need to be able to recognize when your patient is in one of these 3 lethal rhythms, the VTAC, VFib, or asystole, and alert a paramedic and let them know that, you know, at this point now we're working a cardiac arrest. So I hope that that was, you know, pretty clear and straightforward. And as always, if you have any questions, feel free to contact me. Hopefully this will be a good review for you guys, and if you find it useful, I'll do some more videos and post them up on Blackboard. So study hard, and I will see you in class.